Assalamu alaikum. Welcome everyone on board. Uh, Yesterday we discussed about appendicectomy, and yesterday my response was that is there anyone who has not anesthetized a patient for appendicectomy? And today my question is the other way around: that how many of you do work in interventional neuroradiology? Because it's not available in every setup. Even I have not done much of it. And today I happen to work in intervention neuroradiology. So I just thought to discuss few of the things about this topic. Anyone who has worked in interventional neuroradiology, or if anyone want to just speak out, what do you think will be the challenges if you are working in this angio suit in general, and specifically for the procedures which require general anesthesia or sedation or monitored anesthesia care with reference to interventional radiology. Okay, so anyone wants to speak out, please? Silence.
Mhm. Sir, few cases we have observed. These patients may have critical morbidity and neurological deficit is there, and
Okay.
they suffer from severe hypotension, bradycardia, even hemorrhages may occur, and loss of life can occur.
Okay, so actually, first of all, it is non-operating room anesthesia. Yes, Dr. Zubair, please. Zubair bhai, yes, you can speak out.
Sorry, my mic was mute. Actually, this is a very interesting topic and very challenging one, and also very confusing one to dealing being an anesthetist actually. So, what Dr. Rishan asking the concerns, yes, there are very challenging concern in these type of cases. First of all, this is the remote location. Number
Yes.
two, most of the time they present as an emergency situation. Number three, as one of the participants says, that a neurological deficit, which may ranges from aphasia to the low GCS. And number four, the plan of anesthesia, what plan of anesthesia we should offer or we should decide. This is one of the best challenging, decision which I ever across in my practice.
Sure.
Why? Because these patients, for example, is they come after the stroke. Usually their GCS sometime, even 12 to 13, sometime even less than this. And to decide whether to go for the GA or go only with the local anesthesia or with sedation only is also become very challenging, because if the GCS in between 12, 13 or 10 to between 10 to 13, then uh, if we decide to go with only with the local and sedation, background sedation, then during the procedure, any movement, any reflex can cause loss of airway from us, and that
Yes.
can cause the hypoxia and the other things. So in between, to deal with this remote location with all the C arm around and limited access, it can end it in a disastrous situation. And I had seen these type of things in my practice. So these are the challenges which usually we came across in these kind of cases.
Yes,
Thank you.
you have just rightly highlighted. Actually, this is an unfamiliar environment. We have limited manpower. It's out of OR. Not everyone is there. Okay. Then all the problems, because there will be some problems which will be related to the environment. So environment is unfamiliar, manpower problem. Then this is usually a cold place, very just like MRI. Sort of, you can say that if we combine MRI and this intervention radiology suit, so these are the problem. MRI, of course, there will be something extra. Then another problem is that the table operation, this operating table, which in on which they are operating, it is not like our operation table in which we can move have head down, head up. It is a straight table. So it is a big problem because especially for people like me who always make a RAM position for manipulation or after, like there are so many things which is for which you are not mentally prepared usually. Okay, this is an addition. If you just exclude the patient type and the other thing, then it's a sort of very, you can say that it's such a tricky situation. And actually, they don't need anesthesia actually because it's not a painful procedure. But anything can happen, especially if they are manipulating or if they are opening, just like in cardiac cath, arrhythmias can occur, bleeding can occur, and it can lead to it, it might require some open surgery to shifting of the patient to the open surgery. So because anything can happen, the patient can have any neurological problem preoperatively and can develop a new development of neurological problems. Okay, so because this when they open it, patient can have fits, patient can have altered level of consciousness, like or any neurological deficit can occur post procedure. So these are the things which you should be thinking about. And then in addition to that, because usually, for example, if we just think that it is opening of some treatment of some ischemia or some aneurysm, okay, this patient definitely will have involvement of other vessels like peripheral vascular disease or ischemic heart disease, okay, or hypertension. Okay, so they will come with a bag full of problems and bag full of diseases. So you have to be very careful about how to proceed with it. Okay, for example, the cases which I did was today was carotid stenting, okay, and cerebral angiogram. So just there may be some other procedure. Just I will just show you the text about it. Just a second. Okay, so in Pakistan, I think at least in two hospital, Lahore General Hospital and NICVD, they are doing these cert procedures. So mainly they will be either image
Sir,
guided.
also in MH, in military
I'm
hospital,
sorry.
they are also doing. In military hospital, Rawalpindi, they are also doing that.
Very good. Will this you are talking about AFIC?
No, sir, in military hospital, MH, in which hospital I'm working,
Okay,
आज ही मैंने
okay,
case
very good.
कराया उससे.
So yeah, yes. Can you just share your experience? Which procedures usually you people are doing, Dr. Abid?
Sir, actually, there are two suits, a
Can
free
you
suit
can
and
you
there is
speak in English?
neurological cat. Then, yes,
Yes,
sir,
I'm
in
sorry to
neurological cat.
interrupt you. I'm sorry to interrupt you.
Yes, sir.
Abid, just speak out in English because there may be some people who don't understand our
Okay, sir.
language.
Sir, actually, in a neurology suit, they do the clipping of aneurysms.
Okay,
And
aneurysm
other
clipping, one of them.
procedures are uterine artery embolization and other procedures are also being done. But in neurocath, they do the clipping of aneurysms.
Okay, are they
And
doing this acute stroke management?
yes, sir, they are also doing the stroke management.
Okay, okay.
I happen to go there just for today. I'll share
Mhm.
my experiences afterwards in your text messages with you because I have recently been posted to this hospital.
Okay. So you see some of the procedure name endovascular treatment of cerebral aneurysm, coiling or embolization, endovascular treatment of AV malformation, fistula, intracranial, dural, spinal. Okay, preoperative embolization of cerebral spinal tumors. Because at the moment we are just focusing on neuroradiology, but these procedures can be done for other conditions as well. Embolization for epistaxis, investigation and treatment of idiopathic intracranial hypertension, sclerotherapy for venous angiomas, balloon angioplasty for carotid stenosis and vasospasm. So I was actually doing this case today. Intra-arterial chemotherapy, okay, treatment of acute thromboembolic stroke, okay, stereotactic surgery in which they are doing a minimum invasive approach, and they are doing the mapping so that the angle at which they are approaching is very good, and they are able to get the results in a just give me a second. Actually, my father is calling. Yes, sorry for the interruption. Some pain procedure. So assessment, because I have told this before as well, that whenever you are talking about neurological involvement, so you should be thinking about sensory involvement, motor involvement, cranial nerves, and autonomic involvement. So this is for actually junior residents, that whenever you are evaluating a neurological system, think about sensory system, motor system, cranial nerves, higher mental function, and autonomic nervous system. So if you chalk out in 4 5 points, it will be easier for you to assess. Is there any sensory deficit? Is there any motor deficit or motor weakness? Is there any problem in the higher mental function? Patient is oriented or not? Patient is having any cranial nerve palsies, and patient is having any autonomic involvement. Okay, so this will be yes, Zubair bhai, you want to add something?
Yeah, actually, not to add something, but just want to get some guideline from you people who has worked in this category. And my special interest actually is the stroke management, as the Dr. Abid told us that he also dealing with this kind of patients. So my question number one is: this a golden period post stroke, in that the neurointerventionalists, they want to do the embolization or antithrombotic
Yes,
therapy? Is any golden
yes.
period exist, and what
Zubair
are
It,
the
bhai, I
results?
it
cannot
does
recall
exist.
the I cannot recall the exact hours, but if you recall ACLS, so in ACLS there is a chapter for stroke management. Okay, so actually I will just tell you an example, that there was an orthopedic surgeon in King Faisal who was found unconscious on the bed, and then he was taken to the intervention radiology suite. He was stunted, and after 1.5 months he was doing surgery. Just after 1.5 months, 6 weeks, he was doing surgery again. Okay, so I think this can explain the wonders which this can facility can do. Okay, so it is just like having an MI and taking the patient immediately to the cardiac suite and opening the vessels. So similar, same theory, same mentality will be there, that if you open up the vessels immediately, the damage will be minimized. Okay. Okay, we will discuss. Actually, this is more related. I will discuss about stroke this, because this open up another topic for me. We will just try to have a discussion of stroke part from ACLS guidelines. Okay, because that we are not dealing every day, so that those things just slip out of the mind. Okay, so the main, usually in these patients, even if you are dealing them, your main goal should be that you should be maintaining the ICP, even if they are doing any procedure, if you are giving anesthesia, because if they are already manipulating the vessels, so if you manage to not maintain the blood pressure, maybe it can lead to some problems. Okay, so cerebral perfusion pressure should be in your mind, and of course cerebral perfusion pressure will be related to ICP, will be related to the use of inhalational agents, will be used with reference to CO2 levels, and you have to zero the transducer at the level of trigus rather than the normal level which we do for arterial. You have to maintain it at the level of external auditory meatus. So it will just give you an idea about the cerebral perfusion. In addition to that, you can have the neuro monitoring in the form of any high specialized monitoring equipment you have for Zubair bhai, what is the name of the equipment which we use for cerebral monitoring in our hospital? What is the name of that thing which we use?
Mas- Massimo.
No, not Massimo. It's a specific name. Cedar or something. Um, I
Which one
forgot
you are
the name.
talking about? But
Just like
there is
on the
Masim.
for the cerebral monitoring. Massimo company, they have the strip which we place on the forehead. There is a specific name for
Yeah,
it. I
this
forgot.
in
Saturn or something like that. If you recall, you
yeah,
just
maybe
tell us.
that modem is a different one, but the yeah, monitor is the Massimo. Yes, I will check it
Yes.
out.
Okay, so you see the whole of the neurosurgery or neuroanesthesia revolves around the maintenance of the cerebral perfusion pressure. So you have to keep it around 70 to 80, and you don't have to hyperventilate, but you don't have to let the CO2 level go up, and you should avoid hypoxia. And then you have to maintain, even in these cases, if, for example, if you have an aneurysm, ruptured aneurysm, okay, so now this patient will be at risk of going in vasospasm. So these patients, they are using nimodipine, and there was a concept of triple H therapy, so from which now hypervolemia is not stressed as much it was stressed before. So, but still you have to keep hemodilution, that you don't want a hemoglobin of hematocrit of 40, you want to hematocrit have around 30, and you have to maintain maintain the blood pressure, and you don't let the this one vasospasm. So if this will happen, the neurological outcome will be not as promising as if you happen to uh, take care of these things. Okay, so preoperative neurological deficits will be documented, and you have to counsel the patient about any possible outcome, because usually I tell you that these cases can be done even with mild sedation. As I told you, the prick which they do for the femoral access, when they prick it, at that is the time when you just need some anesthesia. After that, actually, there is no pain inside. When they are inside, they are manipulating, there is no pain. Okay, so you actually today did two cases only in monitored anesthesia care, where actually very small amount of dexmedetomidine, nothing dose of dexmedetomidine infusion going, and in addition to that, I some small amount of midazolam. Two cases I did like that. Okay, so actually maybe you don't need anything. So, but you have to be prepared for any catastrophic event. Okay, so okay, actually this is a big topic. I'm just trying to cover as much as possible. So when you are evaluating the patient, in addition to the normal evaluation, there should be what they are doing, how much vasculature is involved, it is unilateral or bilateral, and how much, again I repeat, that what is the pre-operative neurological deficit which is there, because if anything happen after that, you will have an evidence that this was preoperative. Okay, so similarly they have just ECG and imaging, and then actually these are the same thing which are valid for any other place. Yes, very important thing, because in these patients they are using the contrast. Okay, so you should have an eye on the contrast induced problems. So contrast induced nephropathy, contrast induced anaphylactic reactions, and if there is a borderline renal function, it is a relative contraindication for not using any dye or any procedures like that. Okay, they will have to be careful about it. So this is one thing, and then if it occurs, uh, theoretically there is use of an acetylcysteine. I've never used it myself except for ICU for as a mucolator sachet, but actually it is documented to have an acetylcysteine for as a protective. What is in your hand is to have a good perfusion pressures of kidneys if you want to prevent the kidneys, and you should keep the blood pressure, and you should keep the volume status. If the patient is dehydrated, this will be an additional risk factor on top of what they are giving. So like if they give and die, and the patient is already hypotensive, hypoperfused, and you are using NSAIDs as well, so then it will be a big problem. So you just have to pull out any risk factors which you don't use any renal toxic drugs, and maintaining the good homeostatic conditions for the kidneys. So these are the things which you can do with reference to the contrast. Okay. So rest, what is left? So remote area anesthesia, you are not familiar. Radiation safety, yes. Any anesthetist who is frequently working, there should be a band, and it should be recorded, and there is mechanism to record how much radiation doctor that physician has exposed, and if it is going towards some danger sign, you should be keeping yourself away from that area for some time. Similarly, that the lead apron which we are wearing, actually sometimes we say that it has everything except for lead. So unfortunately, this is a big problem. So we have to take care about it. And because radiation can cause a lot of problems, especially in females, but also in males, fertility issues and development of carcinoma and everything. Okay. So radiation safety is another problem. Patient access neuroradiology. MRI is separate. So I'm not using MRI at the moment. MRI we will discuss separately. Okay. But all the monitoring guidelines you have to follow. And yes, we know when there is aneurysm is not ruptured, you actually try to have hypotension. Like, no, you don't allow the blood pressure to go high up. But if it is ruptured, then you have no don't have to let the blood pressure go down too much. Okay. So this is something. Then they are using anticoagulation, IV heparin they are giving, and the patient already maybe on it. Okay. Mm, Aspirin, these patients are on aspirin and clopidogrel. Of course, you are not doing, usually we are not doing any blocks in these patients. If there is any like anticoagulants patient is taking. So hemodynamic stability, maintenance of adequate cerebral perfusion pressure, patient immobility. If you are giving like sedation, this is a big problem. This is a big challenge that patient should not move. Okay. Because if, for example, if patient is moving his head, even if they are not approaching from a distant place, but if the patient is moving, the studies will not be reliable. Okay. So it can cause the problem. So the patient cooperation is very important. Luckily, I had very nice patients today, so I was able to. But this should be in your mind that if you are trying to do this procedure under sedation, patient cooperation is of utmost. If patient is moving, patient is not able to lie flat on the bed, you cannot do it under sedation. Okay, you will have to put something, either supraglottic airway or intubation. This is especially in cases when you are doing it as an elective procedure. But if in an emergency, you cannot do, I think most probably you will have to intubate the patient. You cannot put supraglottic, or even it will be a challenging thing to do with the sedation. Okay. Mm, I saw Dr. Nasrullah also around. Nasrullah bhai, would you like to add something? Okay, so actually, these are the things, the number of things I have already told you. And patient can bleed, procedure can fail, vessel can rupture, hemorrhage can occur, anaphylaxis, nephropathy. Okay. Yes, because they are doing it from the groin, as I told you. So sometimes it can create these problems as well. Okay. They are usually doing the puncture with the help of ultrasound. Okay. Vessel occlusion, vasospasm, and delayed cerebral ischemia. Delayed cerebral ischemia is a clinical syndrome of focal neurological or cognitive deficits, or both, occurring typically 4 to 12 days after following aneurysmal subarachnoid hemorrhage. The term delayed cerebral ischemia encompasses a number of clinical entities. This is something specific about it. That's it. I just wanted to share this topic. Of course, this sometimes some things are. Tell us about, I don't know, dyslexia. This is not the domain at this moment, Dr. Humera. Okay, we will discuss it at some other time. Okay. So anyone wants to ask anything, any comment you want to do about this specific topic? I will share these sources just to wrap up. Actually, this is a FRCA mind map. Where it has gone. Okay. So as I told you, procedures, what are the general procedure? MRI, angiography, embolization, stereotactic surgery, sclerotherapy, balloon angioplasty, thrombolysis, okay? Uh, for cerebral aneurysm or AV malformation, preoperative assessment, like specific concerns with neurological assessment. CVS, I don't know what they have written, caticulum and release, but of course, CVS involvement will be the respiratory system. Okay. Special consideration, unfamiliar hormone, dim light, transfer between CT, MRI, ITU, radiation, radiology equipment moving. They are, yes, another thing is that if you are giving GA, remember one thing, you need to have a very big circuit because they are moving up, down, right, left, and the tube can come out very easily. So you have to be very careful. It's not in one position because they are moving in too much movement. They are doing it. Okay. So you have to be very careful about it. Uh, and you don't need to give too much because maybe in sometimes they are doing immediate post-operative evaluation. Okay, just a second. Then with the conduct of anesthesia, pre-med on individual basis, monitoring and equipment, catheterize, avoid venous obstruction. We need to mix a little head side up, okay? Arterial line, CVP and arterial line is better because any cardiovascular instability can occur. So it is better for you to have arterial blood pressure monitoring. Okay, goes vascular stress because patient can bleed. And induction with propofol opioid, it like in these patients, if you are using one agent in a high dose, it can create more trouble. So you can use a cocktail of medications, nullifying each other's side effects and getting good effects, or you can use cardiac stable medication, like for example atomidate, if you have any doubt. But I never use atomidate. I use a combination of propofol, midazolam, fentanyl, ketamine, dexmedetomidine, background music. So it gives a very smooth and very nice induction. Okay. And then Tiva, avoid nitrous, of course. Remifentanil, if you have, it's a blessing. It is wonderful. Mild hypocapnia. Not, it is not hypocapnia actually. It is maintenance of uh, CO2 around 33 to 35. Okay. And unsecured a post-operative, even despite it seems to be a simple procedure, it is better for these patients to be, if they have underwent any manipulation, it is better to monitor the patient in HDU because there may be any uh, post-operative problems. Okay. Complication as hemorrhage, intubation, vasoapic drug. It's not actually, I am in some mind maps are very good. It doesn't seem to be a very compact one. Okay. So this is another source. Okay, I think it's enough for this topic. So we will come back with some other topic. Thanks a lot, all of you, for your presence. Any comments or any question? Abid, I would be waiting to listen from you. Okay. Uh,
Sure,
you
sir. I
know,
have just asked my neurologist now to share the protocols, the local protocols which they are having. They do consider the golden hour, even the golden minute. They do consider,
mm,
and there is a protocol for this hospital that when the stroke patient arrives, it is
mm,
he's immediately transferred to the HASU and the interventional lab. The neurologists are always there. One neurologist is
mm.
24/7 present.
Okay. Okay, so thanks a lot, all of you. Inshallah, we will discuss some other topic, inshallah, soon. Okay, bye bye.